Welcome to the Funnel Effect. Today we are undertaking a deep dive into, well, a really critical document for anyone in cardiac care. It's the comparison of the latest ESC, AKNC, ACCP HRS, and CCS guidelines on the management of atrial fibrillation. In this comprehensive review, it was meticulously put together by Julian Wolfs, Christian Ellerman, Jarrett Vermeyer, and Lars Eckert. Our mission today, its focus may be a bit ambitious. We're going to cut through all the, institutional variations. We want to understand the nitty-gritty differences in how the world's big cardiology societies, that's the European Society of Cardiology, the American Coalition, so aka CPHRS, and the Canadian Cardiovascular Society, how they each approach atrial fibrillation, or AF. Now, it's really crucial to remember, they're all looking at basically the same science, right? The same big multinational studies, the same evidence base, but their final recommendations, they do diverge. And that's based on how they interpret things, their sort of philosophy on risk versus reward, maybe resource availability in their healthcare systems, and this is key exactly when they publish relative to some big clinical trials.
So we need to find those essential variations, the subtleties that really determine what happens on the ground in clinics. We want to give you the shortcut, really, to being well-informed on global AF care. Okay, let's unpack this. Let's start right at the beginning, the structure of these documents.
Yeah, it's fascinating. And that framing is perfect. I mean, when you dig into the source material, you see this core agreement on a lot of patient management strategies. It really confirms there's a strong global evidence base. But like you said, those subtle differences, they often hinge on, well, philosophical decisions, a country's tolerance for risk, its health economics, or just how it reads one big randomized trial. And those are the nuances, right? They decide whether a patient in, say, Toronto gets a different treatment, or maybe at a different time than someone in Berlin or Chicago.
Exactly. So let's start right there. Structure and the kind of conceptual frameworks. Do these guidelines fundamentally look the same? Or are we talking three totally different beasts here?
Structurally, they're actually very similar. All three, ESC, ACCA, and CCS, they all have this sort of textbook-like feel. They all cover the basics, the pathophysiology of AF, the epidemiology, and then they move step by step into detailed management recommendations. But the first kind of big structural difference, it jumps out right away in how they grade the evidence. How strong are these recommendations? How certain are we?
Okay, let's nail that down. We're kind of used to the U.S. and European system, that class 1 IIIB stuff.
Yeah.
How does the Canadian approach differ?
Right, so both the ESC and the American group, the ACHA coalition, they use that established ACC Foundation HA methodology. That's the one with the big tables detailing the recommendation strength. Class 1. Benefit way outweighs risk. You absolutely should do it. Class IA. Benefit still outweighs risk. Reasonable to do it. II. Benefit might be greater than or equal to risk, so you could consider it. And Class 3, no benefit or even harm. And then they pair that with the level of evidence. Level A is multiple big trials. B is maybe one good trial or strong non-randomized studies, and C is more consensus or expert opinion. It's designed to be really descriptive, really detailed.
Very prescriptive, yeah. It gives the clinician not just the what to do, but the how confident are we in the data behind it.
Precisely. Now, the Canadian guidelines, the CCS, they take a really different path. They use the GRADE system that stands for Grading of Recommendations, Assessment, Development, and Evaluations. GRADE doesn't really rely on those huge detailed evidence tables. Instead, it focuses more on the certainty of the evidence and the balance of benefits versus harms. And this translates into shorter, often more direct recommending texts. So the practical upshot is the CCS guidelines, often seen as more concise, more focused on that certainty aspect, whereas the ECH and ESC guidelines, they give you this exhaustive documentation of all the studies underneath.
Okay, so structure differs. Concise certainty with CCS versus exhaustive detail with ACA and ESC. And this kind of administrative difference, it seems to flow right into how they frame their whole philosophy for managing AS. It looks like the old simple ABC approach isn't quite cutting it anymore.
Absolutely. And the introduction of these new acronyms, it signals a really major conceptual shift. It's a big novelty. This shift really acknowledges that AF isn't just, an electrical glitch in the heart's upper chambers. It's more of a systemic disease, deeply embedded in a whole context of cardiovascular risk factors.
Right. Let's look at the ESC's framework first, this AF care. The order seems really deliberate there.
It is very deliberate. ESC introduced AF care, and the C, crucially, stands for comorbidities. And they put it first. That's followed by A for avoiding stroke and thromboembolism, then R for rate and rhythm control, and finally E for individualized evaluation and follow-up. Putting C first, that's a direct statement. It's saying, look, sustained effective AF management has to start by treating the whole patient, their entire risk profile.
Wow, that really is a strategic shift.
Yeah.
treat the biological environment, the context, before you zero in on the electrical fix.
And the U.S. guidelines, they take this idea and basically triple down on it. They've adopted 3 distinct frameworks. Their foundational layer, it tackles the diagnosis and really intensive management of comorbidities. And that's summarized by the acronym HEAD 2 TOES. That's heart failure, H, exercise, E, arterial hypertension, A, diabetes, D, tobacco, T, obesity, O, ethanol, E, and sleep apnea, S.
Just that one acronym, HEAD 2 TOES.
Yeah.
It covers pretty much the patient's entire metabolic profile, social habits, activity levels.
Yeah.
It basically mandates that the cardiologist can't work in a silo, right? They have to connect with primary care, maybe lifestyle specialists.
Exactly. It forces that holistic view. And then that list of comorbidities, it's framed by 2 other layers. The 3 sort of central pillars for ongoing management are SOS, stroke risk assessment, S, optimizing modifiable risk factors, O, and symptom management, S. And then overarching all of that, their kind of ethical and access principle is the 4 A's, access to all aspects of care for all.
Okay, that is a lot of acronyms. HEAD 2 TOES, SOS, 4 A's. I have to ask, practically speaking, does having these 3 layers make it maybe a bit less wieldy in a busy clinic compared to the simpler ESC AF care model?
That's a fair point, a fair challenge to the practical application. I mean, it's comprehensive, definitely, but the multi-acronym approach of the ACA group could introduce some complexity, sure, but the core message, the really key conceptual novelty here, it's universal across both the US and European guidelines, both stress tackling comorbidities early on. They recognize that if you can sustainably treat those underlying drivers, the high blood pressure, the obesity, the sleep issues, you're actually improving the atrial substrate itself, the heart tissue. And that approach, it helps avoid recurrences. It prevents adverse events much more sustainably than just focusing on isolated AF therapy, like, ablation or rhythm drugs alone.
Okay, moving on from the structure, let's talk classification. How do they actually classify the disease? For decades, everything was driven by that PPP pattern. Paroxysmal, persistent, permanent. Is that still the main language?
It's still there, yeah, it's retained, but definitely with serious modifications and, frankly, critiques. All 3 guidelines still use the descriptive T pattern. The ESC, for instance, they've added first diagnosed AF and long-standing persistent AF, meaning it's lasted over a year, recognizing that prolonged duration is its own challenge. However, the source material itself, and really the broader scientific community, points out some pretty profound shortcomings if you rely only on that TPP classification.
And the biggest issue is that just knowing how long an episode lasts, that time-based thing, it doesn't really tell you how severe the disease actually is in that patient, does it?
Precisely. It's descriptive, not mechanistic. Someone with paroxysmal AF, episodes that stop on their own, they might actually have a higher burden, meaning they spend more total time in AF than someone classified as persistent. And the duration. It doesn't reliably predict the risk of it coming back or how well rhythm control strategies will work long term. Crucially, that TPP pattern, it gives you very little insight into the underlying atrial pathology, the fibrosis, the structural changes happening in the heart, and it doesn't clearly point to the best treatment choice, which is exactly why the US guidelines pushed for a more, predictive model.
That makes total sense. If you're serious about treating AF like a progressive disease, you need staging, right? So like we have for cancer or heart failure, something that captures the whole journey from just being at risk all the way to end stage. Tell us about the ACHA staging approach.
Yeah, this is a major update, and it really reflects that global conversation about AF getting worse over time, progression. The U.S. guidelines brought in 4 progressive stages, and importantly, they extended the concept backward to include the time before AF is even formally diagnosed. So stage 1 is the patient who is just at risk of AF, maybe they have hypertension, obesity. Stage 2 is pre-AF. Here you see structural or electrical abnormalities like a significantly enlarged left atrium, things that increase risk, but they haven't had symptomatic AF yet. Then stage 3 is established AF, and that's where they use the traditional PPP substages, paroxysmal, persistent. And finally, stage 4 is permanent AF.
That immediately changes the conversation for someone in stage 1 or 2, doesn't it? Allows for really early lifestyle changes, comorbidity management, long before you're even thinking about rhythm drugs or procedures. It fits perfectly with that head to toes idea.
It really does. And there's another interesting detail. Within that stage 3 classification, the U.S. guidelines include a very specific substage that the ESC doesn't mention, successful AF ablation. By giving patients who've had, say, pulmonary vein isolation their own distinct status, the ACHA is acknowledging that their risk profile, their management path, it's fundamentally changed, maybe permanently altered, even if they might relapse down the road.
That's fascinating, actually, building the therapy into the classification itself. How does CCS, the Canadian guideline, position itself in this classification discussion?
CCS takes a more functional approach, classifying AF based more on the cause, the etiology. They distinguish between primary AF, which follows that typical, often progressive course we've been talking about, and secondary AF, which happens because of some reversible or self-limiting factor. Think an acute infection, hyperthyroidism, maybe recent surgery. The ESC calls this trigger-induced AF. And this distinction is really critical because if you have secondary AF and you successfully manage that trigger, you fix the thyroid issue, for example, the AF might resolve completely. That totally changes the outlook from lifelong management to maybe just monitoring.
Okay, before we move on from classification, we have to touch on valvular versus non-valvular AF. That used to be a huge deal, especially for choosing anticoagulants. Where does that stand now?
Yeah, that distinction. It's largely obsolete now for most clinical decisions. Both the ESC and the ACHA guidelines explicitly state they no longer recommend using that subclassification broadly. However, they are in complete absolute agreement on one very narrow, very critical point. Vitamin K antagonists, VKAs like warfarin, they must be used if the patient has moderate to severe mitral stenosis or a mechanical heart valve. Now, this isn't really a knock on the newer direct oral anticoagulants, the DOACs. It's simply recognizing that the big randomized trials looking at safety and effectiveness for DOACs in those two very specific, very high-risk situations, that data is still quite limited.
Got it. So valvular is mostly out except for those two key exceptions where VKAs are still mandatory. Okay, we've got the structure, we've defined the disease. Let's look at primary prevention. This is ground zero for AF care and head to toes. What's the consensus on lifestyle?
Oh, the consensus here is really robust. We're talking level A evidence for many things. Things like maintaining a normal body weight, definite weight reduction for overweight or obese patients, promoting an active lifestyle, absolutely stopping nicotine, and optimal control of blood pressure and diabetes. These are Class I recommendations pretty much across the board. It signals that these are non-negotiable foundational parts of care.
But where we see some divergence, and this often reflects maybe cultural norms or public health policy, is alcohol consumption. There's a clear numerical difference between the ESC and the ACHA guidelines here.
Yes, the difference is quite specific. The ESC takes a more restrictive stance. They recommend limiting consumption to 3 or fewer standard drinks per week. That's quite low. In contrast, the U.S. guidelines are, well, substantially more lenient. They recommend 1 or fewer standard drinks per day, which, averages out to 7 drinks a week.
That's more than double the weekly allowance. Clearly different interpretations of how low to moderate alcohol intake impacts AS risk. And the ESC, they've recently really doubled down on lifestyle, haven't they?
They have. Compared to their 2020 guidelines, the ESC significantly upgraded their recommendations. Comprehensive risk factor management for overweight obese patients, specific tailored exercise programs, and reducing alcohol consumption, these have all been bumped up to Class I recommendations. What that signals is, for the European Society, lifestyle modification isn't just an optional add-on anymore. It's considered a core medical intervention with validated effectiveness, basically on par with drug therapy for sustainably preventing and managing AF.
Okay, now we wade into the screening debate. This is a really crucial area because we know asymptomatic AF is an independent stroke risk factor. So detecting it early seems logical, maybe universally beneficial, yet the guidelines diverge quite dramatically here. Seems to be based on economics and how high they set the evidence bar.
This really is a philosophical crossroads in global cardiology, isn't it? The goal is clear. Detect that hidden subclinical AF that significantly bumps up stroke risk. The Canadian guidelines, CCS, they recommend opportunistic screening for patients aged 65 or older. This is very practical, cost-effective. Often it's just simple pulse palpation during a regular doctor's visit. And it's backed by cost-effectiveness studies like SafeU.
Okay, opportunistic pulse checks for 65 plus. Ooh, what about ESC? They seem more proactive, recommending systematic screening in some cases.
Yes, ESC goes further. They also recommend opportunistic screening for those 65 and up, but they add a Class II recommendation for systematic screening for patients aged 75 or older, or for anyone at high stroke risk, regardless of age. Remember, Class II means it is reasonable to do. So they're leaning towards early detection, strongly suspecting that earlier intervention is beneficial, even if we don't have massive definitive screening trials, yet proving it beyond doubt. They also add a little technical warning. simple photoplethysmography, the tech in many smartwatches, they specifically say that's not enough for a formal diagnosis. You still need ECG confirmation.
And right here is where the contrast is just stark. The ACCP HRS, the U.S. guidelines, they stand completely alone by offering no recommendation for general population screening.
Okay.
That's not just a weaker recommendation, it's an active decision not to endorse it. Why such a firm stance against proactive screening?
Well, it really boils down to the pretty stringent criteria the U.S. guidelines apply for public health interventions, especially those that require significant resource allocation. They point to two main limitations. First, they feel there's limited data truly demonstrating that general population screening, especially if it involves costly devices, actually translates into proven positive effects on hard endpoints specifically. Does it reduce stroke rates or mortality? And second, and this is the big financial hinge, they basically demand that any such widespread intervention must be shown to be cost neutral, or at the very least highly cost effective, before they'll recommend it for broad implementation.
So the U.S. philosophy is essentially, show us the level A evidence that screening saves lives, and prove it won't break the healthcare bank before we make a universal recommendation.
That's pretty much the intellectual framework, yes. They're skeptical about rolling out a major public health policy based on, say, Class IA evidence or strong suspicion when the economic impact could be huge. It's a classic tension, isn't it? Between that preemptive clinical suspicion we think this hunks, the demand for definitive, large-scale, cost-effective trial data. It really highlights how local economic models can shape guideline writing just as much as the clinical data itself.
Okay, let's shift gears now to stroke risk assessment and deciding on oral anticoagulation, OAC. This is where those risk scores come in and where we see significant differences, especially around the role of gender.
Yes, this point of difference is probably one of the most heavily debated in clinical practice right now. All the guidelines use risk scores, of course, to do that critical balancing act, weighing the stroke risk against the risk of causing a major bleed with the medication. The ACA, ACCP, HRS, they stick with the traditional standard, the CHA2 DS2 VASCUS score. And that score includes female sex category, the SE part as one of the potential risk factors contributing points.
But the ESC made a really definitive, almost controversial move by completely eliminating gender from its scoring system. They must have had a strong reason for that.
They did, and it's based on their read of the evidence. The ESC recommends the CHA2DS2VA score, intentionally dropping the S for sex gender. Their main scientific rationale is that the data suggests female sex is really only a significant risk factor when it's the only risk factor present. If a woman has even one other risk factor, like hypertension or diabetes, her total risk profile seems to be driven almost entirely by that second factor. Gender becomes weak as an independent predictor in that context. So by excluding it, they argue it simplifies clinical decisions. And, as a secondary point, it also moves towards a more inclusive score that better reflects the evolving understanding of non-binary individuals in clinical settings. They essentially prioritized clinical relevance and simplicity over keeping a weakly predictive factor.
That is a fascinating move. Prioritizing simplicity, maybe modern social context, alongside their interpretation of the clinical evidence that the predictive power of female sex alone is pretty negligible.
Now, contrast that again with the Canadian guidelines. CCS recommends the 3HA65 score. This one is dramatically simpler and very heavily focused on age. It really prioritizes age being 65 or older as the main trigger for considering OAC. While it's simple, the downside is this score omits quite a few crucial risk factors that the VA and VAS scores capture, things like peripheral artery disease or symptoms of heart failure.
Let's make this really concrete. Let's use those two patient examples from the source material. They really highlight the practical impact of these different scoring systems. First, a 70-year-old man, no other health issues, no comorbidities.
Okay. Under the CCS guidelines, using CHA65, he's 70, so he's over 65. He gets an immediate indication for OAC, simple as that. But under the ESC, using CHA2DS2VA, and the ESIS, using CHA2DS2VAS, because age is his only risk factor, OAC is only something that should be considered. It's a class of the CI recommendation. That leaves the final decision more to the physician's discretion, considering the individual patient context.
Wow. So a clear yes in Canada versus a maybe, let's discuss in Europe and the US, for the exact same patient. Now, let's flip it. Example 2. A 50-year-old woman, but she has peripheral artery disease, PAD.
Right, so this patient scores higher on the more comprehensive scores because of her PAD. And in the U.S. case, the CHA2DS2 VASC, she also gets a point for being female. So both the ESC and the ACH guidelines recommend effective OAC for her. It's a class ORO indication. They see her as being at significant risk. But because she's under 65, the CCS guidelines relying heavily on that age-centric GHA 65 score, they would likely recommend just antiplatelet therapy like aspirin for this patient.
That example really drives home a potential flaw in the supersimplified score, doesn't it?
Yeah.
The younger patient, but with significant underlying vascular disease who clearly seems high risk based on the comprehensive scores, might end up with what the other guidelines consider suboptimal therapy. The choice of risk pool literally dictates whether she gets protected from stroke or not.
Exactly. And, the cumulative nature of those more detailed scores, the VA and VASC, it's essential for identifying patients who are at exceptionally high risk, someone scoring a 5 or 6, for example. For them, stopping OAC even briefly could be incredibly dangerous. The CHAT 65 just doesn't give you that level of granularity, that risk stratification. And another point, because it's simpler, the CCS score also leaves out other important factors like aortic plaques, which previous studies have pretty consistently shown carry their own independent stroke risk.
Okay, moving from who gets treated to what they get treated with. Choice of anticoagulant. Is there any lingering debate about aspirin? Does it have any role left in just preventing stroke in AF?
Absolutely none. The consensus here is powerful and unanimous across all guidelines. Antiplatelet agents, mainly aspirin, are explicitly not suitable for stroke prevention in AF by themselves. Their only role might be in specific combinations with OAC, usually for a short time after procedures like getting a stent, PCI, or having a left atrial appendage occlusion, LAAO device implanted. The guidelines overwhelmingly prefer the direct oral anticoagulants, the DOACs like dabigatran, rivaroxaban, apixaban, edoxaban over the older VKAs like warfarin. And that's based on solid evidence showing they're just as good, non-inferior at preventing stroke, but with a significantly lower risk of intracranial bleeding, which is a devastating side effect.
But the ESC does introduce an interesting nuance about older patients who are doing really well on VKAs.
They do, and this is a great practical point for clinicians. Based on data from a trial called FRAIL AF, the ESC guidelines specifically advise against automatically switching a patient who is over 75 years old to a DOAC if they are already tolerating their VKA well, have stable INR control, and are perhaps already managing multiple other medications, polypharmacy. For these specific, often frail patients, the thinking is that switching might just disrupt a stable regimen, add complexity, and the slight extra benefit and bleeding reduction from the DOAC might not outweigh the risks associated with changing things up. It's basically an instruction to prioritize clinical stability in the elderly.
Makes sense. Let's talk about left atrial appendage occlusion, LAAO. This is the structural approach, plugging the appendage where most clots form, as an alternative to pills for some patients.
Yes, LAAO is a really key intervention, but specifically for a defined group. Patients who are at high risk for stroke but have documented serious reasons why they cannot take long-term oral anticoagulation. Think recurrent, major bleeding episodes without a clear, fixable cause. All three guidelines agree that LAAO is a viable alternative in this specific high-risk group with contraindications to OAC.
But the strength of that recommendation differs, doesn't it?
Yeah.
Which often kind of reflects how much solid evidence they feel they have to back it up.
Precisely. The ACCP HRS gives a stronger Class T recommendation for LAAO in this group. That signals greater confidence it's reasonable to do this. The ESC, however, perhaps reflecting a slightly more cautious interpretation of the long-term safety data for LAAO devices, gives a weaker Class IB recommendation it may be considered. So a subtle but definite difference in confidence level.
And what about surgically closing the appendage, say, during other necessary heart surgery? This seems like a perfect example of how publication timing relative to a big trial can cause guidelines to diverge.
Oh, this is a textbook case of exactly that. Timing is everything here. Both the ESC and the AJA guidelines came out after the results of the LAOA's third trial were known. That trial showed something crucial. Surgically closing the left atrial appendage during another cardiac operation like bypass surgery was beneficial in reducing stroke. But, and this is the key part, only when the patient also continued taking oral anticoagulation afterward. Therefore, both ESC and ACCA recommend surgical LAO plus continued OAC for patients undergoing cardiac surgery who also have the CCS guidelines, however. They were published before LAS there came out, so they only recommend surgical occlusion for patients who already had a contraindication to OAC to begin with. They essentially miss that key, finding that for most patients, surgical LAO is meant to be an add-on to OAC, not a replacement for it.
Fascinating how one trial can shift things so clearly. Okay, let's move into section 4. Anticoagulation in special circumstances. These are those acute situations, the ones that really challenge decision-making in the moment. Starting with cardioversion, shocking the heart back to rhythm, which we know carries its own immediate stroke risk.
Right. The rules for a planned elective cardioversion are pretty straightforward and uniform. The patient needs to be on effective OAC for at least 3 wints beforehand. The complexity comes in with unplanned acute scenarios. If the patient is hemodynamically unstable, you cardiovert immediately, no question. But if they're stable and the duration of the AF episode is unknown or unclear, all guidelines agree the safest path is to do a transesophageal echocardiogram, a TOE, to look directly into the atrium and rule out a clot before delivering the shock.
Okay, so TOE if duration is unknown. But where do they differ on how long the AF can have been going on before you must do a TOE, even if the patient seems stable?
Yeah, the divergence is around how long they're willing to let stable patients go without needing that pre-procedure imaging, assuming the onset time is reasonably certain. The ESC is the most liberal here. They suggest that cardioversion without prior OAC or a TOE could be considered if the AF onset is documented to be within the last 24 hours. The ACCP HRS is a bit stricter. They say there's no clear evidence needing a pre-interventional TOE or even post-interventional OAC, only if the AF duration is definitely less than 12 hours and the patient's baseline stroke risk using CHA2DS2 VASIC is very low, score of 0 or 1.
And the Canadian approach on this 12 versus 24-hour window?
The CCS also focuses on that 12-hour mark. They recommend cardioversion without a TOE if the AF onset is known to be less than 12 hours. And interestingly, they say this is okay regardless of the patient's underlying stroke risk score. However, if the duration is known to be between 12 and 48 hours, they only waive the need for a TOE if the patient is very low risk, using the older CHEETS-2 score, 0-1. Practically speaking, though, given that accurately documenting the exact onset time of AF is often really difficult, the default in many places remains TOE-guided cardioversion unless the onset is absolutely reliably confirmed as being very recent.
Makes sense to err on the side of caution there.
Yeah.
Next special circumstance. Catheter ablation. We know this procedure involves creating controlled damage in the atrium to block AF signals, which inherently creates a temporary state where clots could form more easily. How is OAC managed around ablation?
This is actually an area with very high consensus now. OAC must be started before the ablation procedure, and critically, all guidelines now uniformly advise against interrupting OAC or using heparin bridging around the time of the procedure itself. This practice, called uninterrupted anticoagulation, is now standard. Then, post-procedure, OAC must be continued for a fixed, relatively short period to allow that acute inflammation and thrombogenic state from the ablation to settle down. The ESC says at least 8 weeks, while the ACCP recommends 3 months.
Okay, OAC before, during, uninterrupted, and for 2-3 months after. But what's the crucial teaching point for patients about what happens after that initial healing period? If the ablation seems successful, can they stop their anticoagulant?
Absolutely not. And this point is hammered home universally in all the guidelines. The decision to continue OAC long-term is determined entirely and solely by the patient's individual stroke risk profile, assessed using their CHA2DS2 VASC score, or equivalent. It is not dictated by the perceived success or failure of the ablation procedure itself. So a patient could have a seemingly perfect ablation result, be in sinus rhythm all the time, but if their risk score is still high, they absolutely must remain on OAC. Now, there are ongoing trials, like the OCEAN trial you mentioned, investigating whether long-term OAC might be safely stopped in very selected patients after highly successful ablation, maybe guided by intense monitoring. But for now, the guideline consensus is crystal clear. If your risk profile says you need OAC, you stay on OAC regardless of ablation outcome.
That's a vital message. Now let's pivot to maybe the hottest area of recent debate, subclinical AF, also called device-detected AF. This is AF picked up by pacemakers, defibrillators, or implanted loop recorders, often without the patient feeling anything. This seems like the poster child for guideline differences driven by the timing of recent high-impact clinical trials.
Oh, absolutely. This section perfectly illustrates how quickly guidelines can change or diverge based on real-time data integration. The AKA ACCP HRS guidelines were published before the final results of 2 key trials, NOAS AFNET6 and Artesia, were fully available and analyzed. Based on earlier, mostly observational evidence suggesting these device-detected episodes carried significant risk, the U.S. guidelines took a relatively proactive stance. They recommended considering OAC individually, based mainly on how long the atrial high-rate episodes, AHREs, lasted. Specifically, they gave a fairly strong Class IIa indication, reasonable to consider, for OAC, if an episode lasted 24 hours or longer and the patient had other stroke risk factors, CHA2DS2 VASC or EO2.
So under the U.S. guidelines at that time, if your device picked up a solid day of this subclinical AF and you had other risk factors, OAC was strongly suggested.
Exactly. But then came NOAS AFNET6 and Artesia, and they significantly tempered that enthusiasm. NOAA-AFNET-6 basically showed that routinely anticoagulating these patients did not significantly reduce the main combined outcome of stroke or systemic embolism, but it did increase bleeding. Artesia showed a modest benefit for apixaban over aspirin in reducing stroke, but the overall event rate was much lower than expected, suggesting the baseline risk in subclinical AF is considerably lower than in clinically apparent AF. The message was, the risk is there, but maybe not as high as we thought.
Okay, so the big trials came out after the U.S. guidelines, but before the European ones. How did the later ESC guidelines incorporate this new, somewhat cautionary data?
Right. The ESC guidelines had the advantage of timing. Published after these crucial trial results were known, they could incorporate this negative finding from an OA and the lower than expected risk shown in Artesia. Consequently, they adopted a much more cautious stance. They gave only a weaker class II indication, meaning OAC may be considered, for using DOX in patients with asymptomatic device-detected AF, and they specifically recommended against it for patients already known to be at high bleeding risk. It's a classic example of a recommendation weakening from II down to II based on high-quality randomized controlled trial evidence.
A direct impact of trial timing.
Right.
And the CCS guidelines, where did they land?
Well, the CCS guidelines actually predate both of these large randomized trials entirely, so understandably they offer no clear recommendations specifically for OAC and device-detected AF, simply because the necessary level of evidence required to make a firm guideline statement just didn't exist at their time of publication.
Okay, one last special circumstance. Postoperative AF, or POAF. This happens fairly often after major surgery, especially heart surgery. What's the recommended long-term management strategy if someone develops AF right after their operation?
POAF is indeed common. The ESC takes the view that if a patient develops POAF and already has an underlying increased risk for thromboembolism based on their baseline factors, COCH2DS2, they should probably receive long-term effective anticoagulation, treating it similarly to other forms of AF. The U.S. and Canadian guidelines, however, advocate for a slightly more conservative wait-and-see approach. Both the ECCE and CPHRS and the CCS recommend reevaluating the patient's stroke risk after a set period 60 days for the U.S. or 6 to 12 weeks for Canada after the surgery. This difference likely reflects studies suggesting that while POAF definitely increases short-term risks like mortality around the time of surgery, it might not necessarily translate into a permanently increased long-term thromboembolic risk for all patients once that major surgical trigger is removed. They're essentially asking clinicians to reassess the baseline risk factors once the dust settles before committing the patient to potentially lifelong OAC just because they had POAF.
Right, a period of reassessment.
Yeah.
Okay, let's shift now to the fundamental strategic decision in AF management. Rate control versus rhythm control. It feels like the consensus has really swung towards prioritizing rhythm control much earlier in recent years.
Yes, absolutely. The pendulum has definitely swung. There's now a strong, established worldwide trend away from just defaulting to rate control, especially early on. The new focus is really on utilizing rhythm control strategies earlier in the disease course, with the aim of actually influencing disease progression and reducing major adverse outcomes down the line. And the key driver for this shift, which both the ESC and AJUST guidelines explicitly credit, is the EAST-AFNET-4 trial.
Okay, let's unpack the impact of EAST-AFNET-4. What did that trial really prove about intervening early with rhythm control?
EAST-AFNET-4 was genuinely pivotal. It tested the specific hypothesis of implementing rhythm control early, typically within the first year of AF diagnosis, compared to waiting until symptoms necessitated it, which was the older strategy. And it demonstrated clear prognostic benefits for the early rhythm control group. This included a significant reduction in a tough composite endpoint: cardiovascular death, stroke, or hospitalization for heart failure or acute coronary syndrome. The benefit seemed particularly pronounced in patients who also had underlying cardiovascular risk factors. So, as a direct consequence, both the ESC and the ESTUFI ACP HRS guidelines now give a Class 2 recommendation should be considered, or is reasonable, to evaluate a rhythm control strategy for patients with recent onset AF less than 1 year, specifically to reduce those adverse cardiovascular outcomes.
So early rhythm control is no longer just for symptoms. It's about changing prognosis. Rate control isn't the easy default path anymore. Rhythm control has to be actively considered up front. But if the decision is made to go with rate control, perhaps in an older, less symptomatic patient, what are the heart rate targets? Incorporating what we learned from older trials like RACE2 and AFFIRM.
Yeah, the targets vary slightly, but they all uniformly reflect the key finding from RACE2, that a more lenient rate control target is often just as good and potentially safer than trying to achieve overly strict control, at least in many patients. The ESC recommends the most lenient target, simply keeping the resting heart rate below 110 beats per minute. The ACCP HRS is similar, recommending a target between 100 and 110 beats per minute, but they specifically mention this is for patients with a normal left ventricular ejection fraction, LVEF.
And CCS, usually a bit stricter maybe.
Typically, yes. The CCS guidelines recommend a slightly tighter target of less than 100 beats per minute when the LVEF is preserved, greater than 40%. And they also explicitly advocate for stricter targets if the LVEF is reduced, less than 40%. This likely reflects some caution stemming from subgroup analyses in RACE 2, which raised concerns about lenient control specifically in patients with reduced heart function.
Okay, targets mostly lenient, maybe tighter with heart failure. What about the drugs used for rate control? Digoxin is an old drug, but it seems to have had a bit of a comeback or a status update in these guidelines.
It definitely has. Based largely on the findings of the RATE-AF study, which directly compared digoxin to beta blockers in older patients with AF, the ESC guideline essentially upgraded digoxin. They now give it equivalent status to beta blockers as a first-line option for rate control, particularly suitable perhaps for elderly or more sedentary patients where beta blockers might cause fatigue or other side effects. Similarly, the ASC ACP HRS gives digoxin a solid class I indication, specifically for patients who have AF and coexisting symptoms of heart failure. It's recognized as a really valuable agent in patients where beta blockers might be poorly tolerated or even contraindicated.
And what happens if standard drug therapy just fails? The heart rate stays too high despite trying different medications or doses.
If the rate remains refractory, meaning you just can't get it controlled adequately with medications, then all the guidelines agree that atrioventricular AV node ablation should be considered. This involves basically cutting the electrical connection between the atria and ventricles and implanting a pacemaker to control the ventricular rate. This is particularly relevant for maybe older patients who are less symptomatic from the AF itself but bothered by the fast rate, or crucially for patients who have a cardiac resynchronization therapy, CRT device for heart failure, but are getting suboptimal benefit because the fast AF rhythm is interfering with the device's pacing. The ACAA CPHRS specifically recommends AV node ablation combined with biventricular pacing CRT for HFrEF patients with an LVEF below 50% as a way to improve quality of life and potentially even boost their ejection fraction by ensuring consistent pacing.
Right, the Abley and Pace strategy for refractory rate control. Now let's talk about using drugs for rhythm control antiarrhythmics aimed at keeping the patient in normal sinus rhythm. A key safety concern here revolves around the class I antiarrhythmic drugs like flecainide and propafenone. Where the guidelines differ on defining the significant structural heart disease that makes these drugs potentially dangerous.
Yeah, this subtle difference in definition is really crucial because these class I drugs carry a risk of causing dangerous ventricular arrhythmias, proarrhythmia, if there's underlying structural damage to the heart muscle. The ACCP-HRS restricts their use in patients who have had a previous myocardial infarction, heart attack, and/or have significant structural heart disease, which they often define using LVEF specifically, an LVEF of 40% or less. The key phrase there is previous MI.
And how does the ESC define the restriction? Is it broader?
The ESC's restriction is arguably a bit broader, perhaps more cautious. They restrict the use of these drugs in patients with severe left ventricular hypertrophy, thickened heart muscle, heart failure with reduced ejection fraction, HFrEF, or any form of coronary heart disease, even stable disease without a prior MI. However, it's worth noting the ACHA's slightly more liberal stance regarding patients with stable coronary heart disease without prior MI or low EF is somewhat supported by more recent evidence suggesting careful use might be acceptable in selected cases. The CCS adds another layer of vigilance here, recommending an annual checkup, specifically looking for any new symptoms of coronary artery disease in any patient maintained long-term on flecainide or propafenone.
Okay, so subtle but important differences and contraindications for class I drugs. What about the other mainstays like amiodarone and dronedarone? You mentioned they come with heavy caveats.
Absolutely heavy caveats. Amiodarone is undeniably highly effective at maintaining sinus rhythm, but it's often relegated to second-choice status because of its significant long-term side effect profile. It can seriously impact the thyroid, lungs, liver, eyes, skin, the list goes on, requires careful monitoring. Dronedarone was developed as an alternative, structurally similar, but without the iodine moiety thought to cause some side effects. However, its use is severely restricted by a major warning based on historical trials. It was found to increase mortality in patients with established symptomatic HFrEF and also in those with permanent AF. So dronedarone is generally limited to patients with paroxysmal or persistent AF who do not have significant heart failure. a crucial limitation.
And we also have to acknowledge the geographical reality. Not all drugs are available everywhere, creating another source of guideline divergence, right?
Yes, this is a clear-cut case where drug availability due to regulatory approval simply dictates what can be included in a guideline. The drug dofetilide is recommended by the ACC/HRS. They give it a Class II recommendation as a reasonable option for long-term maintenance of sinus rhythm, particularly in patients who have both AF and HFrEF. It's shown to be effective and relatively safe in that specific high-risk group. However, dofetilide is simply not approved for use and therefore not available in Europe. Consequently, the ESC guidelines don't even mention it as an option.
Can't recommend what you can't prescribe. Okay, finally, let's turn to catheter ablation. It's become a cornerstone therapy, especially when drugs fail or aren't tolerated. But the big question now is, when should it be considered first line, before even trying drugs?
Yes, this is a major area of evolution and growth. For paroxysmal AF, that's the earlier stage where episodes start and stop on their own, there is now overwhelming consensus based on multiple strong randomized trials. Both the ESC and the ACCP/HRS have upgraded first-line catheter ablation, meaning offering it as an initial therapy option alongside drugs, to the highest possible recommendation level, Class I, Level A. The evidence supporting its efficacy and potential prognostic benefits in improving quality of life and reducing AF burden in symptomatic patients is just too strong to ignore anymore.
Okay, Class I, Level A for first line and paroxysmal AF.
Yeah.
Strongest possible recommendation. But when we move to persistent AF, where the AF is continuous and the atrial substrate is often more diseased, the strength of that first line recommendation clearly diverges between the guidelines.
It diverges significantly, yes. The CIACP/HRS gives a stronger Class CA recommendation for considering first-line ablation in selected patients with persistent AF. Their decision is partly influenced by studies like the SARA trial, which suggested benefits for early ablation even in symptomatic persistent AF. However, the ESC, perhaps reflecting a more cautious stance on the long-term success rates versus risks when dealing with more advanced atrial remodeling in persistent AF, assigns only a weaker Class II recommendation for first-line ablation in this group. So again, you have the U.S. guidelines saying it's reasonable to consider this upfront, while European guidelines are saying, well, it may be considered. A clear difference in enthusiasm for early intervention in persistent AF.
And what about patients with heart failure? Ablation has shown some really impressive results in improving symptoms, quality of life, and maybe even outcomes in that very high-risk population.
Yes, for symptomatic AF patients who also have heart failure with reduced ejection fraction, HFrEF, all the guidelines agree that catheter ablation is a suitable and often preferable strategy compared to just drug therapy, aiming to improve symptoms, reduce hospitalizations, and potentially even improve survival. They all cite the same seminal trials like CASTLE AF and ATAC to support this. However, once again, the strength of the recommendation differs slightly. The ASCA/AFC/HRS provides a Class I recommendation for ablation in selected HFrEF patients, a very strong endorsement to proceed if the patient is suitable. The ESC, while agreeing on the benefit, gives a slightly weaker Class III recommendation. Now, this is quite remarkable because, as you said, both societies are looking at the exact same underlying trial data. The SHA seemingly interpreted the results, particularly the mortality benefits seen in CASTLE-AF, as being robust and generalizable enough to warrant that top-tier Class I recommendation, while the ESC opted for the slightly more conservative, reasonable-to-do Class DS stance.
Interesting how the same data can lead to slightly different levels of recommendation strength. Let's talk technique briefly. Pulmonary vein isolation, PVI, electrically isolating the triggers in the pulmonary veins, that's the cornerstone, right? But what about doing more? Adding complex extra ablation lines or targeting areas of scarring to address the underlying structural damage, especially in persistent AF.
PVI is absolutely the mandatory foundation, the cornerstone of virtually all AF ablation procedures in all guidelines. The debate and uncertainty lie in whether ablating beyond the pulmonary veins, targeting things like complex fractionated atrial electrograms, CFAEs, low voltage areas indicative of scarring, or drawing linear ablation lines actually improves long-term outcomes, especially in persistent AF. The ACCP/HRS acknowledges this uncertainty. They note that the value of adding these non-PVI endpoints is currently unclear and assign only a Class I BEB recommendation, may be considered, to such additional ablation. The ESC is even more conservative on this point. They basically give no further specific recommendations on techniques that go beyond PVI, citing the persistent lack of robust, large-scale randomized data definitively showing long-term superiority over a PVI-only strategy, particularly for persistent AF.
So stick to the basics. PVI seems to be the message until more data comes in. What about hybrid ablation? This combines a minimally invasive surgical ablation on the outside of the heart with a catheter ablation on the inside, often used for difficult-to-treat persistent AF.
The guidelines differ here too, and this might reflect varying institutional experience and perhaps access to the specialized teams needed for hybrid procedures. The ACC HRS seems to favor hybrid ablation primarily for persistent AF, giving it a Class II recommendation. The ESC, in contrast, assigns a stronger indication. They give hybrid ablation a Class III recommendation for persistent AF, suggesting higher confidence in its efficacy in that setting. And interestingly, they even assigned an indication Class II Level B for using hybrid ablation in paroxysmal AF, which seems quite aggressive and likely reflects a belief in some centers that this combined approach might be highly effective in achieving durable rhythm control even earlier in the disease process for selected patients.
Okay, we've covered a huge amount of ground, comparing structures, philosophies, screening, risk scores, anticoagulation, rate versus rhythm, drugs, ablation. So pulling it all together, what does this entire comparison tell us about where AF care is heading? Where is the science moving? And what are the major unanswered questions, the gaps in evidence that the guidelines themselves, particularly ESC and ASACIA, say need to be filled?
Yeah, the future research sections in these guidelines are really illuminating. The focus is almost entirely shifting towards personalization and prediction. A major theme is questioning the very definition of AF and really understanding the role of AF burden. Future studies need to rigorously examine that historical 30-second duration requirement for diagnosing AF. Is that arbitrary? Does shorter subclinical AF matter? And the guidelines explicitly state that AF burden, the total amount of time a patient actually spends in AF, not just whether they have paroxysmal or persistent label, needs to be measured and used much more frequently. Not just for deciding on anticoagulation, but also for evaluating how well rhythm control strategies are actually working. We need to move beyond asking, is the patient in AF today, to asking, how much AF does this patient have over time, and what is the biological consequence of that burden?
And if we're going to detect AF earlier, possibly through screening or wearables, we desperately need better validated tools, right? Especially given the U.S. guidelines focus on cost effectiveness. What's the urgent research need there?
Absolutely critical need. We urgently need studies that validate the clinical benefit of these photoplethysmography-based systems, the smartwatches and other wearables. We need hard endpoint data evidence showing that using a watch for screening actually translates into fewer strokes, better survival, and that it's cost-effective. Furthermore, those somewhat surprising findings from the big subclinical AF trials, NOAA AFNet 6 and Artesia, showing a lower than expected stroke risk, they raise profound questions. Have we been overestimating the thromboembolic risk in the very earliest phases of AF detected only by devices? If the answer turns out to be yes, that really challenges the whole premise and especially the cost effectiveness of widespread general population screening.
It sounds like the emerging science on subclinical AF risk is directly bumping up against the philosophy behind the ESC's proactive Class II recommendation for systematic screening.
It absolutely is. The data, as it stands now, suggests that for many patients who might be picked up by screening, their actual short-term risk might not be high enough to clearly justify starting OAC with its associated costs and bleeding risks. This continuous refinement of risk, especially at the very low end detected by devices, is absolutely essential.
Another major gap seems to be true personalization. We have these big conceptual frameworks, head to toes, AF care, stressing a holistic, personalized approach, but we still seem to lack the refined biological tools to truly stratify patients effectively.
Precisely. We don't have highly effective ways yet to predict reliably which patient is going to progress rapidly from paroxysmal to persistent AF, or which specific patient will benefit most from early ablation versus a drug strategy. We need to better define the role of non-traditional risk factors. Things like genetic markers, biomarkers of inflammation or fibrosis, imaging techniques that show signs of atrial cardiopathy, those subtle structural changes in the atrium that happen even before AF starts. We need to integrate these into better personalized risk prediction models. This would hopefully allow clinicians to identify much earlier which patients truly need aggressive early rhythm control and which can be safely and effectively managed with perhaps a simpler rate control strategy.
And what about innovation in the anticoagulants themselves? Are we looking beyond the current DOACs?
Yes, researchers are definitely exploring novel anticoagulation concepts. The main goal is always to find drugs that reduce stroke risk even further while minimizing bleeding risk. The big area of focus recently has been targeting factors higher up in the coagulation cascade, specifically factor 11 and factor 12 inhibitors. The theory is that inhibiting these factors might prevent pathological clot formation, like in AF, while leaving normal hemostasis, the body's ability to stop bleeding from injury, relatively intact. However, this path is proving challenging. We just saw the disappointing results from the Oceanic AF trial. It tested a factor XI inhibitor, asundexian, against the well-established DOAC apixaban in AF patients. The trial had to be stopped early because asundexian was actually shown to be inferior to apixaban in preventing stroke and systemic embolism. So while the search for even safer anticoagulants continues, perhaps with different targets or approaches like pill-in-the-pocket anticoagulation for very low-risk patients, the Oceanic result really underscores that improving upon the safety and efficacy profile of the current DOX is an incredibly high bar to clear.
A high bar indeed. And finally, for refinement in the ablation field, what do the guidelines demand there? More effective techniques, better patient selection.
Both, really. They demand greater selectivity and much more long-term data. There's an urgent need for better ways to stratify patients before ablation, using perhaps non-invasive imaging to characterize the atrial substrate, or biomarkers to identify those individuals in whom the procedure is most likely to provide durable long-term success. The ESC in particular really emphasizes the need for robust, randomized data to clarify whether those extra ablation lesions beyond PVI ablating low-voltage zones doing linear lines truly add sustained benefit for patients with complex, persistent AF, or if they just add procedure time and risk. Additionally, there's a clear need for multi-year outcome data on the newer ablation energy sources, like pulsed field ablation. PFA. PFA shows immense promise in terms of potentially being faster and safer, causing less collateral damage. But it's still relatively new, and we lack the many years of follow-up data that underpin the Class I recommendations for older technologies like radiofrequency or cryoablation. So, to try and summarize this huge comparison, despite everyone working from essentially the same fundamental scientific knowledge base, we see these profound, clinically significant differences across the ESC, ACH, and CCS guidelines. These variations pop up everywhere in how they classify the disease that move from descriptive PP to the more progressive staging approach. In stroke risk assessment, highlighted by the ESC's bold stance on excluding gender from their score. In the whole philosophy of screening, pitting that rigorous U.S. demand for cost-neutral level A evidence against the European clinical drive for earlier detection. And these underlying philosophical and data interpretation differences, often driven by publication timing relative to key trials, significantly impact the strength recommendations for core therapies. We saw it with LAAO, with how to manage OAC in subclinical AF, and definitely in the decision whether to push for catheter ablation as a first-line therapy, especially for persistent disease.
It really feels like the constant tension weaving through all these guidelines is between needing administrative simplicity, you need rules clinicians can actually follow globally, and the growing scientific push to treat atrial fibrillation as the truly progressive, highly individualized disease it is. Based on how consistently the source material emphasizes defining AF by its underlying pathology, the atrial remodeling, the disease burden, maybe the future of AF classification won't use episodic time measures like paroxysmal or persistent at all. Perhaps instead it will focus entirely on quantifying the substrate, measuring the extent of atrial fibrosis or electrical dysfunction, making that shift to a truly predictive substrate-based classification. That could utterly revolutionize how early we intervene and who gets these advanced therapies. It would finally make the philosophies behind head, two toes, and AF care not just concepts, but measurable, actionable reality for patients. Thank you for watching The Funnel Effect.